to our participants and audience of Eternal Heart Conclave 2020, Day 2. My task today to continue the advancement in the field of stable coronary artery disease and present you the data about the choices which we do when patients are confronted with stable CAD, whether you should continue medical therapy or should do a PCI or send this patient for coronary artery bypass surgery. Now, before, what I'll do is I'll divide this topic in two parts. One, appropriate use criteria for PCI. So which patient should get the PCI is the important issue, or continue medical therapy. Second, once it is complex PCI, should you go for CABG or PCI or just or the hybrid approach, combination of two? There probably medical therapy alone will not be enough. Before we decide that question, we always have to see the overall scenario of a patient in stable CAD. I just want to remind everyone that patient with acute coronary syndrome, patient with STEMI, PCI is the standard therapy, and it has been supported by various guidelines, and those patients undergo PCI successfully. But in stable CAD, there have been a lot of controversy that maybe medical therapy is good enough. Maybe every patient should not get the stenting. And so therefore, before we make that decision, we need to consider patients whether have angina, ischemia on the stress test. It turns out to be both are equally important. And then, is there a lesion concordant to ischemia, and is lesion suitable for PCI or CABG? And also that what should be the endpoint for the PCI strategy. Studies have shown that PCI is done to reduce angina or ischemia and to improve exercise tolerance. It does not decrease death or MI. I'll start with illustrative case of this one 61-year-old, a patient who presented with the class 1 angina, has a positive stress as mildly ischemic, and was on aspirin, ACE inhibitor, and simvastatin. An angiogram showed, as seen here, that significant lesion in the branch of the circumflex, which is the LPL. And you can see here, long lesion, about 80-90%. Other vessels are fine, right coronary and the LV function is normal. So this case, what do? We know that majority of these patients are managed medically, whether they are in India or they are in United States. Only 7-8% patients go for PCI, and then 2 or 3% goes for coronary artery bypass surgery, and largely because the medical therapy has failed in these patients. We have done multiple trials in stable CAD of medical therapy versus PCI, RITA2, ACME, MASS, AVERT, and MASS2, and all of them showed that PCI does better job of angina relief, and of course there's no difference in death, mortality, and MI, and those are the guidelines that PCI can safely be deferred in patients with stable CAD as per the guidelines. Now, this whole question came into debate when COURAGE trial was done in mid 2000s. Basically, about 2,400 patients with the stable CAD were randomized to PCI plus medical therapy or stable medical therapy, maximum medical therapy group, with a death and MI at 5 years, which we knew no of the trial have shown any benefit of the PCI. And exactly what happened, that at 5-year follow-up, you can see the death MI and stroke all were identical. Yes, PCI led to a lower revascularization as shown in the COURAGE trial. Within the COURAGE, there were embedded nuclear sub-study. And what was that? The patients who had a baseline nuclear stress test, and then they had the medical therapy or PCI, then at 18 months had a repeat nuclear stress test, and showed that in terms of ischemia reduction of more than 5%, PCI did a better job, 33% compared to medical therapy. Also learned that if you reduce ischemia more than 5%, your outcome is better. 13% death and MI compared to double, almost 25% at 5 years. So it seems to be that we learned that overall, there's no difference of PCI or medical therapy. And of course, if patient breaks through, you can always do PCI in these patients. And secondly, the PCI, somebody who is ischemic, PCI does the better job. And since then, there have been many other studies in terms of patients who have objective evidence of myocardial ischemia. And it seems to be that patients, the PCI definitely do a better job in improving their outcome. And with without that part of definite ischemia, there are various randomized trials of PCI versus optimal medical therapy, as you can see here, that in terms of mortality or MI is identical. So there's no difference that PCI does not improve the myocardial infarction or death in these stable patients. It does improve angina and the quality of life. So why so? Because we know that in acute coronary syndrome, it's a thin cap and basically rupture of the plaque take place. And therefore, and that can give rise to MI and death. Compared to stable CAD, it is a thick cap and it does not rupture. It just causes angina because it causes gradual obstruction of the lumen. And therefore, it's a supply and demand mismatch called ischemia and angina, which we know medical therapy is given. So once you have acute coronary syndrome, you need to do PCI rapidly, and that has shown to be beneficial. But if you have stable CAD, medical therapy is good enough. But many patients will break through medical therapy and then will require PCI. So that's basically what we learned overall. And this led to the guidelines, which we call appropriate use criteria, OC, in 2009 and then 2012. And they took into 4 important characteristics of a patient. One, how is the symptoms, which angina class patient is, based so also the non-invasive risk assessment, low, intermediate, or high risk, or patient on maximum medical therapy, particularly anti-ischemic, nitrate, calcium blocker, beta blocker, or renologine, and what is the coronary anatomy finding. And it's very interestingly, they made a simple grid. This is patients who are low risk or non-invasive on finding or asymptomatic. And basically, if you plot the whether patient has in terms of the non-invasive risk and medical therapy, along with coronary artery disease in the bottom, you can come up with a grid: A, appropriate; U, uncertain; I, inappropriate. That means patient who have one vessel disease, not medical therapy, low risk ischemia, should not have PCI. If you go to a little more the symptomatic, which is intermediate risk, class 2 angina and intermediate ischemia, you can see inappropriate. We don't want to be in the I category, which is the red. So basically those, most of them are either appropriate or uncertain, but some cases are still inappropriate, even with the class 1 or 2 angina and intermediate risk finding on the stress test. Now, high risk finding or class unstable angina, class 3 or 4, all of them are appropriate or uncertain. So therefore, it's a nice guideline for the interventionalist to deal with these patients when they encounter. So let's go back and put this into our patient who has a class 1 angina and he has a one vessel disease and was not on anti-ischemic therapy and has a mild ischemia. So where will this patient fit in? It will be in the inappropriate category. So what you do, despite having a 80-85% lesion, that patient is discharged home, was started on medical therapy, and we also learned from the Courage trial about 1/3 of them will break through and will have more angina and then can go through PCI safely. So this patient basically continued to have symptoms after about 3.5 months, despite medical therapy, and came back. And at that time, we went ahead and opened up this blockage, put a Zena stent in this particular case, excellent results, and patient was discharged home same day with antiplatelet therapy and aggressive CAD risk factor modification. So this is just to give the thought that patients with single vessel disease or two vessel disease who have minimal symptoms, not on medical therapy, it's okay to increase medication and then see how patients do, and many of them will stabilize. But if they break through, they can always undergo PCI. So based on that criteria of appropriate, uncertain, and inappropriate, the data came from ACC-NCDR, which is the American Registry of PCI, that about 11.6% patients in the elective cases were inappropriate. Now, in acute coronary syndrome, inappropriate number is very small. And so that's basically shows that clearly that patient, the acute coronary syndrome, the inappropriate is like less than 1. So, but in a stable CAD, almost 11 to 12% patients could be inappropriate based on that OC criteria. Now, there's the data from the New York State was similar, was 13.4% inappropriate, and that time Mount Sinai had 3.7% inappropriate, and we actually continues to have that number less than 5%. And this is what I say, that some cases will need to be done because you can go, patient, they don't read the book and you have to manage the patient. So many times you have to do what is right for the patient, but that number should be less than 5% and try medical therapy first. And we know initial medical therapy does not harm the patient. And I'll show you subsequently with another trial. So this what happened is, and this is one classical example of a tool which was identified to be beneficial and was implemented. And with a guideline directed treatment of of patient with stable CAD, and that led to, as you can see here, overall inappropriate number. There is a data from North Carolina, which used to be 26% before, and then in next 5-6 years became less than half. And clearly this tells you that overall power of education and following the guidelines. Now we actually went beyond. So many times you have a lesion looks like 60%, maybe 80%, but this is the angiogram, which you see here. But then we have additional tools which can identify which of these lesions will give trouble. And one of them is doing the ultrasound. Ultrasound is looking inside like I was, like ultrasound of the artery, intravascular ultrasound, and they come up with a lumen if less than 4 millimeters square for the non-left main, 6 millimeter for left main, and clearly these patients do better if you do intervention. Less than that, you can do medical therapy. Second, that on the OCT, which is more refined IVUS, it basically really tells, is like the 10 times more sophisticated and more detailed than compared to IVUS, and really tells you the cap thickness. We know that thin cap ruptures, which is defined as less than 60 microns, and thicker cap don't rupture. So those thin cap, you may point that these are the patients should be more aggressively treated, whether they should be treated by stent. There's actually trial prospect to absorb, going to present the data. Then thirdly, what about the lipid content, which is called near infrared spectroscopy? And if you have a high lipid content, those are the lesions which closes and cause acute coronary syndrome at follow-up. While these are all anatomical, we also then went to the physiological, called fractional flow reserve, FFR. And the field really mushroomed after the initial data of FFR. That is, that whatever lesion you have, you give adenosine and look at the gradient across. So FFR is less than 0.8. It shows that these patients, despite medical therapy, will not do good. So you need to go more aggressively in these particular cases. So therefore, FFR less than 0.8 should get PCI, but more than 0.8 can be managed medically. And this actually, these are the various points. One of them, as I mentioned, based on the lipid content, which is the thin cap fibroatheroma and overall plaque burden, can really tell you in a stable patient that who is going to get trouble in the future. And usually trouble is unstable angina. Then based on the IVUS, you can look into the optimization of your stent. And of course, IVUS guided gives rise to a better result. And lastly, the lipid core, lipid content of the plaque, which has shown that non-culprit lesion, those who have higher lipid content, they have a higher event rate at follow-up of 7.2 versus 2.6%. So this is the anatomical. The physiological, which I mentioned, is the FFR, which has really led to many trials, which all showing same message. That is FFR guided or angiographic guided in the red, FFR guided in green, showing the lower event rate with the FFR guided PCI. So minded, many of these lesions are 80-90%. But if the FFR is more than 0.8, can be managed medically. That led to a second trial, FAME2, where patients who are more than 0.8 were the part of registry, because you don't do PCI in them, but less than 0.8 were randomized to PCI or medical therapy, and the trial was halted after 6 months. Why? Because patients in the medical therapy group start having more event. And you can see here that in medical therapy group, those who have FFR or less than 0.8 had an event rate or a revascularization of 20%. That went down to 3% if you do PCI. And many of these patients have myocardial infarction. So this is further follow-up up to 5 years that clearly that the PCI and FFR of less than 0.8 is beneficial. And if you're more than 0.8, which is registry, they do quite well. So no need to do any PCI. Now, since FFR require giving adenosine, the scientists came up with another tool called instantaneous wave-free ratio, called IFR. And IFR doesn't require adenosine and take the diastolic portion of the cardiac cycle and look at the gradient, which we call PDPA. And they came up that IFR of 0.89 correlate with FFR of 0.8. And that led to the two major trials comparing which is better, FFR or IFR. Defined flare and IFR Sweetheart, and both of them showed identical outcome at follow-up, whether you do a PCI or revascularization based on IFR or FFR. So clearly, both are equally usable. So what we learn is that guideline-directed medical therapy in patients with stable CAD, decrease angina, improve exercise tolerance, decrease ischemia, better quality of life, and of course, decrease urgent revascularization and so. So there was a trial done Orbita, which is the double-blind randomized controlled trial, and that was supposed to look at whether if you do a sham PCI, means you think patient feels that had a PCI but did not. So is there a difference in exercise duration time? And it did increase from 11.8 to 28.4 second, 16 second more, but it did not make a p-value because they're supposed to increase by 26 second. But what it did is that improve again the ischemia. Stress echo showed that incremental improvement in the stress echo findings were with the PCI compared to placebo. And since then, there have been numerous papers of invasive exercise hemodynamic before and after PCI have shown that PCI, post-PCI, basically you improve exercise performance, improve perfusion, improve vasodilator reserves, and so on and so forth. So clearly, in symptomatic patient, PCI do a better job. And that led to the major trial called Ischemia, which was just presented in AHA last year. And that was the trial of comparing health effectiveness with medical and invasive approach. Basically, the patient stable CAD, you do a CAT scan, they are not, no disease or left main were excluded. And those patients, those are not unstable. They're stable on medical therapy, but has ischemia on stress test, were randomized to optimal medical therapy plus CAT, or if they are not unstable, they will continue on medical therapy. So with a 3 to 5 year follow-up, and this is a overall about 5,000 plus patient trial. And what did it show? Of course, many of these patients have a moderate to severe ischemia, but they were clinically stable. And what they see is that patients, even in the conservative arm, about 23 to 28% require cath and intervention. And of course, in the invasive group, almost 90+% had a cath, and PCI was done in 80, or intervention was done about 80%, 20% did not have any intervention because of the lesions were very diffusely diseased or so. But seems to be, and of the intervention, 74% had PCI, 26% CABG in this group. So what it learned is that patients with the medical therapy group, maximum medical therapy, about 30% will require revascularization. But the outcome basically was that with this strategy, do you have any difference in death, MI, unstable angina, or heart failure, resuscitated cardiac arrest? Answer to that was numerically in favor of invasive approach, but not significant. Now, if you take death and MI only, again, there is no difference. Numerically, 2-3% better in favor of invasive strategy, but p-value was non-significant. But what we learned is a very interesting finding, and that is for patients with the myocardial infarction, that overall there was no difference, but there is a clear difference that if you have procedure MI, little higher in the PCI group compared to conservative group, but after, if you see spontaneous MI, that not from the procedure, after 1 month of the procedure, you can see that invasive strategy decreased MI at follow-up compared to conservative strategy. So shown that by doing the PCI, you kind of took care of the plaque, and that did not give rise to myocardial infarction at follow-up. They also had a quality of life, that whether patients feel better with by the PCI, and curve moving to the right shows on the invasive group that it does. So patients who are symptomatic did better on the invasive approach compared to conservative. So what we learned from the ischemia trial is that it's okay in stable CAD patients with moderate to severe ischemia that you have durable improvement in the both treatment, and there is no clear-cut winner. But yes, if patient have symptoms, ischemia, the invasive strategy did better job, and also that it decreased the incidence of spontaneous MI. The impact of that decreased MI will take few years to show what it will be. But the key is that we have another approach that these patients can be managed safely. And we always have to talk to the patient before we decide what to do, and that is the main message of the ischemia trial. Now go to the second point, to decide which patient should get CABG, PCI, or hybrid approach. There's another patient which I want to share with you, the 73-year-old patient who is diabetic, has high blood pressure, positive stress test, and was on good medical therapy and referred for CAT. And you see here, this patient has left main disease, and then you have disease in all three vessels. LAD here, this is the ramus, and this is the circumflex, and additional disease in the circumflex downstream. So clearly, multivessel disease, and the right coronary has disease in the PDA also. So this patient has a three-vessel disease and left main, and we call syntax score, which I'll tell you a little bit about that. Each lesion is given a number. Heart function was normal. So question is, should you do PCI or CABG? We learned PCI is easy, uh, taken, patients can get back to work, can be discharged same day. CABG does take little toll on the patient in the hospital for 7-10 days, but gives the long-term durable results. And this actually, this field has been tested by various trials. Main one in this field was the syntax trial. What did the syntax trial? Took the patient with multivessel disease, three vessel, and left main disease, and then they randomized them to CABG or PCI. And they gave all patients a score called syntax score. What is syntax score? Syntax score was any lesion you have. You give a number and come up with the overall number with the blockage of more than 50%. So then they came up with the three groups: low syntax less than 22, intermediate syntax 23 to 32, and high syntax score more than 32. And what we learned, that in the low and intermediate syntax score, both this the CABG, red bar, Texas stent was in the blue bar, were identical. But if you have high syntax score, clearly CABG was winner, has a lower event rate compared to PCI. And that was the conclusion at 1 year. And then these patients were followed for 5 years, and the message remained the same way. CABG versus PCI, identical outcome in the low risk, low score syntax. And once you go to the intermediate, it still remain death and MI, but of course, higher revascularization in the PCI group. But more importantly, in the high syntax score group, as you can see, there is a higher mortality of the PCI, no difference in CVA, higher MI rate, and higher revascularization. So it seems to be that patient with a high syntax score, PCI was inferior using Texas stent compared to CABG. During the same time, did another trial called Freedom Trial, which compared diabetic patient, multivessel diabetic, 2 or 3 vessel, randomized to PCI with the DES or CABG, and basically had the similar message. That is, that the particularly actually in this particular trial, the message was a little different than the syntax trial. That is, that by using CABG, you decrease their mortality. Although you have a lower, of course, you have a lower MI rate, but have a higher stroke rate. So very important message came from the Freedom Trial, that patient with a multivessel disease, comparing PCI with the Texas stent versus CABG. Texas was cipher stent, that the CABG was superior for multivessel disease by decreasing MI and death, and that became the guideline. And then the whole issue, the mushroom, that all these complex patients should go for heart team discussion. That's a class 1 indication. And then you decide, whether talking to the patient and physician, that what to do. And this is the various guidelines, that patient with a 2 or 3 vessel disease with a low syntax score, CABG and PCI have an appropriate guideline. But once you get to intermediate syntax score and isolated left main, it becomes uncertain. And of course, high syntax score and diabetic patients, the PCI is inappropriate as per the guideline. So if I had to give the message that which patient, coronary artery disease patient, should go for CABG or so, I want to share the data of the latest, our second generation stent, knowing all the syntax, and Freedom Trial was done with the first generation stent. And this is the data of the latest trial of the Excel, in which Zion's stent was compared with CABG in about 2,000 patients, and basically showed that at 5 years, the outcome of death, stroke, MI was identical. Now, if you go to the individual endpoint, clearly that death, MI, and stroke, as we mentioned, that was identical. The death is the one favored again CABG. So seems to be that even in patients on a long-term patient with the left main disease, which was patients have a syntax score of 33 or 32 or below, they did better with the CABG from mortality point of view. But if you take other point, the stroke was numerically higher in the CABG group, MI was not different, stent thrombosis was not different, and of course we know the revascularization is always higher in the PCI group. So overall, it message of the Excel trial was seems to be put in this way very clearly, that in the first year PCI was better than CABG. From first month. From 1 month to 1 year, both were identical. From 1 year to 5 years, the CABG was better. So many times we may decide what to do for the patient based on the overall prognosis of the patient. So this is the main slide I wanted to share with everyone, that which patient at this day and age, taken all the data together, are appropriate for CABG as long as their medical condition provides, approves, and it's not prohibitive. One is 3-vessel CAD and the syntax score of more than 32. Then 3-vessel CAD with proximal LED involvement and syntax score of 22. 3-vessel CAD in diabetic. Then 2-vessel CAD in diabetic with proximal to mid LED involvement and syntax score of 22, means 2-vessel has to be complex. And then lastly, unprotected left main with syntax score of 32. So these are the 5 category of patients will be preferentially treated with coronary artery bypass surgery. Now, in some cases, if the simple lesions of the circumflex and RCA, you can do hybrid. Leave the lima for the complex LED and put 2 stents in the 2 or 3 stents in the non-LED vessel. And this actually concept was tested in the hybrid trial, but basically the trial was aborted, and we are going to soon know the results of 300 patients which were randomized. So what has happened now with the advancement of the PCI technique, that gap between the PCI and CABG has decreased significantly, as has been shown now with the Excel trial. So this particular case, which you have a multivessel disease with a syntax score of 32, 33, and left main, in this case, we did the IVUS, left main lumen was 4.8, less than 6 millimeters is significant, and patient was appropriately sent for CABG. And patient has a lima to LED and had uneventful course. So just to say, now if this particular case has a CVA and high comorbid medical conditions, bad COPD, lifestyle or life expectancy is less than one year, this patient can safely undergo PCI also, as we learned from the Excel trial and so. So if I put it together, this is my last slide. The patient with a stable CAD, what we decide based on the non-invasive functional study, that exercise, electrocardiogram, or perfusion, and so. If they're negative, do medical therapy. If they're positive, and you did a coronary arterial, whether you did a CTA or arterial coronary angiography, less than 50%, go to medical therapy. But if you have significant lesion in the coronary angiography, 80+%, then of course the PCI may be suitable, pending that whether who will go for CABG. But more importantly, if it is 40 to 80, 90% lesion, what you do is you do a FFR guidance. At the same time, patients who have prior PCI or typical symptoms, you can skip the stress test, go for directly coronary angiography. And FFR and IFR are the main part of the decision making. Now, we also learned that after coronary angiography, high syntax score, multivessel diabetic, left main with syntax score of 32, they should preferentially go for coronary artery bypass surgery. But those now the patients that do not fall into that category. So we did a FFR, and based on the FFR, you decide. If IFR, FFR positive, get the PCI. But if it is negative, positive, they get PCI. If the negative, the deferral of PCI, just continue medical therapy. And then, of course, in the PCI, use IVUS and OCT guidance for stent optimization, particularly for the complex CAD, and that has shown to improve overall outcome. So this is actually field is evolving, and we know these are the data of the New York State in last since 2003 to 2016, that overall number of the CABG patients continue to decline. PCI was declining also, but last 1 year there has been a little uptick. And what the impact of the ischemia trial will be, likely this PCI number is going to go down further. But overall, it shows the power of medical therapy for revascularization, that many patients, whether simple or complex, do extremely well on appropriate medical therapy. So point is, the patient with a stable CAD need to be carefully followed. The medication should be adjusted, and then react to it, that how patient is behaving. If patient continues to symptoms, then of course angiography, then PCI or CABG are appropriate. But if patients develop decrease in his symptoms or asymptomatic, and stress test becomes negative, that patient can very well be managed medically, irrespective of the coronary anatomy. And thank you very much.